Chapter 18 concerns the mouth, nose, and sinuses. So the structures we're going to be looking at include the mouth and throat, and also 4 different cranial nerves that are going to be involved with those. And you should start learning to recognize those cranial nerves both by their number and their name. So those ones, 5 is trigeminal, 7 is facial, 9 is glossal pharyngeal, and 12 is hypoglossal. Also number 10 should be there. That's the vagus, and because it is involved with swallowing, the vagus. Then the nose and the paranasal sinuses. Structures of the mouth include lips, cheeks, hard and soft palate, uvula, and tongue. If you have any doubts about where those things are, check the book. The mouth serves as a protective gateway both for the digestion and respiratory functions. And other important structures in the mouth include the tongue, teeth, and then gums. Another name for the gums is gingiva, and you'll see gingival meaning pertaining to the gums. And then there's 3 pairs of salivary glands: the parotid, the submandibular, and the sublingual glands. Then as far as the throat, we have the pharynx, which is divided into, the throat is also known as the pharynx. It's divided into 3 parts. The nasopharynx, which you can't see directly unless without special instruments. The oropharynx, you can see part of that, and the laryngopharynx you also can't see normally without instruments. So the oropharynx is the only one you can directly see. And then we have 3 sets of tonsils: the palatine, lingual, and pharyngeal tonsils too. Then as far as the nose, we have the external nose, which we can see. We can also see the nares, and we can assess their patency. The nasal septum we can see part of without instruments. And then inside the internal nose we have superior, middle, and inferior turbinates. And what those do is they're mainly concerned with filtering and warming the air we breathe. So that if you breathe through the mouth, your air is not filtered or warmed, but if you breathe through the nose, it's filtered and warmed by these turbinates. Then we're also concerned with the sinuses. The only ones we're going to be able to see or directly assess is the frontal and maxillary, but there's also the ethmoidal and sphenoidal sinuses. Well, what they do is they add resonance to speech, and they also help decrease the skull weight. If all those sinuses were filled with bone, then our skulls would be much heavier, and our speech would also not be as resonant. So, as usual, we start with the history of the present concern, assuming, of course, that the person came to us with a problem concerning the tongue and mouth or sinuses or something like that. So if it's a problem of tongue and mouth, we'd ask about any sores, any break in skin integrity, any painful areas, because they may not necessarily be aware of a lesion, that they may just complain about pain. Any areas that they've noticed of redness, swelling, bleeding, and pain. Any toothache and any tooth loss. And as far as nose and sinuses, some of the things they might come to would be pain in the nose or the sinuses, a history of nosebleeds, frequent nosebleeds, mucus drainage, or a stuffy nose, and maybe inability to smell or taste, which could be simply from a stuffy nose or congestion, but it also could be a problem with the nerves. Involve the olfactory nerve, the facial nerve, various nerves. Then history of the present concern as far as throat. We'd ask about dysphagia. What is dysphagia? Dysphagia is painful or difficult swallowing. So we wouldn't ask them, do you have any dysphagia? They probably would say, what's that? Well, I'd better say no because I don't know what, I don't want to look stupid. But we ask, do you have any pain swallowing? Is it difficult to swallow? Then sore throat. And also hoarseness. Hoarseness that persists is of particular concern because that indicates a chronic irritation of the larynx and could be possibly a sign of cancer. Then as far as their personal history and their family history, you'd ask about oral, nasal, sinus surgeries, any sinus infections, and then allergies. Allergies is a big subject, a big topic concerning particularly nose, nasal problems, frequent problems with rhinorrhea. And your allergies could either be seasonal, which are caused by differences in pollen, for example. You wouldn't necessarily see anything, and it wouldn't necessarily be something you'd identify, but perhaps you're allergic to some pollen that comes in the air at certain times in your area, and so you know that every March you start suffering from this sinus problems or nasal problems for a while, and then suddenly you move to a different place and you don't experience it anymore, and you never do figure it out, but maybe whatever it is you're allergic to, the pollen, is something that doesn't exist in that new area that you move to, or that maybe occurs during a different time of year in that new area. Other allergies, though, we can also have other allergies that can manifest in the nose and sinuses, and those would include drug, medication allergies, food allergies, or things to environmental substances that we have in either our household environment or the environment at large. Then you'd want to ask about treatments that they used. As always, what treatments did they use before they came to seek help? And then family history of any of these types of problems. Lifestyle and health practices. Smoking, but also smokeless tobacco, because smokeless tobacco is an even bigger risk factor than smoking for oral cancer. And then if they smoke, like oh well, I'm okay, I don't smoke cigarettes, I like cigars and the hookah. Well, that's not so benign, particularly with oral and laryngeal cancers. And you can think about Freud. Freud famously died of throat cancer, and he never smoked cigarettes in his life. He only smoked cigars. Then ask about alcohol. Any uses of like things like braces or dentures. and any problems with grinding of the teeth. So before we begin to collect objective data, we need to collect our equipment. One of the things you really need is gloves, because the mouth is the most contaminated part of your body. We tend to think that the genitalia and the rectum, but actually the mouth is an extremely contaminated part of the body. And if you're going to be doing anything with the mouth, even if you're using tongue blades and the like, you should wear gloves. So you're going to need gloves, you're going to need light sources, and a minimum would be a pen light. You might also want an otoscope, and there are special nasal fittings that you can put on an otoscope to do nasal checks, or some people just use the otoscope itself as the light source if they don't have a pen light handy. A nasal speculum is just a device. A speculum is just like a device to open a cavity. Where we have vaginal speculums that we will see, they're used in the gynecological exam, and a nasal speculum looks a lot like a vaginal speculum, except it's much smaller and doesn't have as many pieces to it, but it's a small, it looks something like a forceps with a funnel at the end that you can use to separate the nasal, to open up the nasal area a little bit so that you can get a better vision. And then we want tongue depressors too. And you may need other things such as 4x4 gauze and things like that as well. So, are we going to do a general oral, nose, throat, and sinus assessment, or a focused one? And you really can't tell when you start. I mean, you may start thinking you're just going to do a general assessment, but you may find things on your general assessment that you want to investigate further, so then it will turn into a focused one. On the other hand, if the patient comes in with a complaint that suggests, say, a problem with salivary glands, they complain of dry mouth, why then you know from the outset that you're going to be you're going to be focusing on those salivary glands. So in the general assessment, it includes inspection of various structures like lips, teeth, gums, and tongue, and as well as the buccal mucosa. And you're also going to inspect the external nose, and you'll close it to note airflow and airflow patency, and you'll inspect the throat, and you'll also note any mouth odor, which I mean, there's some mouth odor is normal, but if it's a very strong mouth odor, that can indicate a problem. Focused assessments, as the name implies, you're going to zero in on specific structures in the mouth and tongue and etc. that where you see a problem. So you might, or where you have reason to believe there might be a problem. So you might do such things as palpating the buccal mucosa, palpating the tongue, and then you'll maybe zero in on some of these salivary glands such as Wharton's ducts and the Stenson ducts. Maybe assessing the strength of the tongue if you have reason to believe that one of the cranial nerves that regulate the tongue strength is impaired. Ability to taste on the anterior portion of the tongue, again, that could be from a cranial nerve problem. Then focused assessment of hard and soft palate or uvula. And then if you looking beyond the external nose, we're looking at the internal nose, that would be a focused assessment. And then palpating, percussing, and transilluminating the sinuses. Now, in this lesson, we're going to cover various things, and we're going to kind of mix them together. We're not just going to cover the general assessment and then cover the focused assessment separately. They're going to be mixed together so that you'll see the various procedures for doing all these different things. So, objective data. You want to inspect lips, teeth, gums, and you're looking for color, any breaks in integrity, any lesions, missing teeth, of course, things like that. And you'll also inspect the buccal mucosa. And you'll probably need a tongue blade. You'll need your gloves and a tongue blade to do this. You'll want to pull back the lower lip and upper lip. You pull back the lips so that you can see the gums. And there's an illustration in the textbook of the nurse doing that. For the stents and ducts, you'll look for them in the buccal mucosa across from the second upper molar. And if you take your tongue, you might be able to feel that on if you on yourself. Maybe you will, maybe you won't. You'll want to then inspect and palpate the tongue, and not just the dorsal lesion as far as one thing that one of the most commonly missed areas for tongue cancer rather, is the area under the tongue. So you want to see the ventral surface of the tongue and have them lift their tongue so that you can see what's under there. Palpate any lesions for induration. What is induration? That would be hardness. Does the lesion feel hard or not? Then Wharton's ducts. Those are another set of salivary glands, and they're on both sides of the frenulum, which is the frenulum is where the tongue attaches to the floor of the mouth, where it's attaching at the bottom of the mouth. There's that little thin piece of skin that attaches, and that's called the frenulum. And to the sides of that are Wharton's ducts. And you'd also want to examine the sides of the tongue. And you might want to test the strength of the tongue, particularly in, say, a stroke patient or somebody with any sort of neurological problem. You'd want to focus on the uvula, the strength of the tongue, those kind of things, as well as swallowing problems. So if you were wanting to test the strength of the tongue, you can have them pushing against the tongue blade, or you could just do it from having them pushing against their cheek, and you could be feeling from the outside of the cheek. Then to assess taste on the anterior tongue, why, you'd put some substance on the that anterior tongue, one of the primary taste sensations like salty, sugar, sour, or bitter. And you'd probably have them close their eyes while you did that, so that because you know, if you were getting it from like a packet or something that was labeled that they could see, you wouldn't want them to see what you were getting. Then the hard palate is the anterior portion of the palate, that's lower, and then it raises up the soft palate is what's behind there. And then the uvula is hanging midline, or it should be midline in the throat. If it deviates, that can be a sign of a cranial nerve problem that maybe they had at some time in the past. Some people just are born with a deviated uvula, so it's not always due to a nerve problem. So, but if it, particularly if it was midline and now it's deviated, that could be a sign of, say, something like a stroke or some other some other neurological condition that caused a cranial nerve problem. And as I said, the odor, you're not, people's mouths are not going to smell very pleasant, but neither should they have an extreme odor either. Then we'll look at tonsils, and there's a grading scale that we use for tonsils where we'll cover that more Oh no, okay, that's covered in this chapter, sorry. So grade 1 is tonsils are visible. And many people do not have tonsils. They may have had them taken out or something, so you don't always see them. But if you see the tonsils visible at all, that's grade 1. And then grade 2, they're midway between the tonsillar pillars and the uvula. So that would mean that the tonsils are each covering about 1/4 of that space between the two walls of the throat, and then the other half of the space is open. Grade 3, the tonsils touch the uvula, and grade 4, the tonsils are touching each other. Then we want to look at the posterior pharyngeal wall. And that may be, normally that should be pink, but in some cases, or many cases, if they come in with a sore throat, you'll see some reddening. Just a little reddening would suggest possibly maybe a viral infection or even a seasonal allergy, something like that. But if it's raw red, why then, and particularly sometimes you may see pus there, some exudate. So that would be something to note. There's a characteristic streptococcus infection. That's a fairly common throat infection that can result in complications, particularly children that have frequent strep heart infections can end up with other complications as a result. Then check patency of airflow through the nostrils, and you do that by either asking the client to close one of them and then see if they're able to breathe air adequately through the other one, or you can close one of them using gloved hands, of course. Then you examine and palpate the external nose for any deformity or asymmetry, any tender areas, and then you can take the speculum and use that and a pen light, or if you have a nasal piece to your otoscope, you can use that to look at part of, you won't really look at the internal nose, but you'll be able to look at the nasal septum and look at the nares, get a better view of the nares. You may see a deviated or perforated nasal septum. That's not uncommon to see. I mean, it's not a frequent thing, but it's not really uncommon either. Then we're going to look at sinuses, and remember we only can see the frontal and maxillary sinuses. You palpate the borders, palpate them for tender, and percuss. You're percussing for tenderness in this case, not for sound. And then you can transilluminate them. And the technique for transilluminating the sinuses is a little tricky, so and you'll need to do this in a darkened room. So read the instructions in the book for the technique for transilluminating sinuses. Sinuses normally do transilluminate. That's the normal. If they don't transilluminate, why, that suggests that they're filled with pus or some other fluid like that. So now that we've done the objective and collected our subjective and objective data, we're ready to do nursing diagnoses. And there's one example given, or well, I think there's more than one, but an example of a health promotion diagnosis would be readiness for enhanced health management of, say, dental health, or readiness for enhanced health management as related to they expressed a desire to stop smoking to improve their risk for to reduce their risk for getting oral cancer or something like that. Risk diagnoses, remember, they just have a related to, they don't have an as evidenced by. So we might have risk for aspiration related to decreased gag reflex. The aspiration hasn't happened yet, but we do have a decreased gag reflex, so we're concerned about a risk for aspiration, and we're probably going to put them NPO, or at least refer them to speech therapy and get some speech therapists working with them to do swallowing exercises. And hand in hand with that might be risk for imbalanced nutrition, less than body requirements related to, well, we made them NPO, or they're aspirating, or there could be a number of other things that could cause a risk for imbalanced nutrition. I mean, remember, the mouth is the gateway to the digestive system, so any problems with the mouth could result in a risk for imbalanced nutrition. Then moving to actual diagnoses. Ineffective health management related to, and notice I changed the one that was in the book. I think in the book it said ineffective health management related to poor dental hygiene. That's not exactly right. Your related to is supposed to be what you think is causing the problem, and it's not their poor dental hygiene that's causing their ineffective health management. It's their inability to do the dental hygiene, right? Well, something is driving that inability. Maybe they can't use their right hand, or maybe it's decreased mental status. So that's why I rewrote that one. I put that as ineffective health management related to decreased mental status, as evidenced by, well, one thing might be poor dental hygiene. There could be other things too, like maybe they forget to take their pills or whatever, but that wouldn't be related to the content of this chapter. Bathing or bathing/oral hygiene self-care deficit related to quadriplegia, as evidenced by poor condition of gums, mouth, and skin. Now, you can put in a lot of other things there, that maybe your patient doesn't have quadriplegia, or maybe their gums are in poor condition but the rest of it isn't. So maybe they have a self-care deficit, and then the related to is what you think is driving it. The as evidenced by is what evidence you have for it. Disturbed sensory perception, olfactory. Remember, that's our first cranial nerve there. Related to mucous membrane irritation. Well, in this case, it's not a nerve problem. We don't think it's a nerve problem at all. It's that they can't move the air through that stuffed, that occluded nose. And it's as evidenced by, we did the smell test that we'll learn about when we get to chapter 27, I believe, 20 or 20, I can't remember. We'll get to the smell test when we do the cranial nerves. And so they couldn't distinguish the smells, but we don't really think that they have a cranial nerve problem. We think that it's just that their nose is totally stuffed up. Impaired swallowing related to cranial nerve dysfunction as evidenced by failed swallow test. Again, that kind of depends. If they just had a stroke, it's quite plausible that the problem is a cranial nerve dysfunction. If they have impaired swallowing and there's no evidence of other cranial nerve dysfunction, maybe that impaired swallowing is something else. It could involve the structures of the pharynx itself, or it could involve a tumor, or it could involve muscles or various things. So you kind of want to think about what goes into that related to category. It should be something that you truly think is causing that problem. And then finally, we could have imbalanced nutrition related to oral mucosa lesions as evidenced by a low BMI. We looked at BMI in our chapter on nutrition. Then collaborative problems and referrals, meaning things that we need some help with. We need help from another discipline, maybe the physician or maybe the therapist or something. Risk of complications for streptococcal infection of the throat. Well, just by looking, we don't know that something's streptococcal, but if we see a beefy red kind of throat with purulent exudates on it, why then that's suspicious for strep, and maybe in the ER, maybe we ran a rapid strep test and it came back positive. So then we don't diagnose, the physician diagnoses, and we certainly can't order anything to treat the strep, but we can recognize, well, yes, that is a strep infection. And then we would refer it to the physician. Then risk of complications for a suspicious buccal lesion. Look in the back of the chapter, and there are a number of pictures of various throats and mouths, and you will see some lesions that are suspicious for cancer, some lesions you would want to report lesions, but particularly things that were alarming looking, you would want to report with more urgency. And then perhaps risk of complications for a deviated nasal septum, or maybe even a perforated nasal septum.